cafeteria. We don't have all the things that's here at Asan Medical Center. It's very impressive on top of the outstanding care that's given here. Well, so as a continuation of looking at methods that are evaluating the best way to resuscitate and to treat patients, I thought that the second topic that I would discuss had to do with critical thresholds, particularly for red blood cell transfusions. So what I'm hoping to do is touch on some of the more salient evidence that pertains to use of red blood cell transfusion, particularly in the critical care setting, what the data is, and really what can we gain from that data from a truly scientific standpoint. But having said that, as you all know, sometimes when you read the science and the literature, it's even more confusing than if you actually didn't do that. But it's very important, I think, in underscoring the approaches that we take in the framework of protocolized care and best practice. So I think that everyone embraces the concept that anemia is very common in critical illness for a number of reasons. One is it may have been due to blood loss, whether it was a traumatic insult or a patient in hemorrhagic shock. The bone marrow is known to not produce red cells in states of critical illness, even in the setting of elevated ferritin levels, for example, because it's an acute phase protein. The problem is that the erythroid cell line is not able to metabolize it in the creation of the heme ring and subsequent hemoglobin. And then, of course, there's always blood draws that will affect this. And I think most certainly there's a multifactorial etiology, but certainly it's well accepted that anemia is extremely common in the setting of critical illness. And then when one thinks about the utility of using red blood cell transfusions, it's really threefold. One is, again, always looking at creating a normal situation, so correcting the anemia. Having said that, we know that that does not always need to happen. Some patients are walking around chronically anemic, for example. Women during their childbearing years, it's not unusual, but they do perfectly fine because there's compensatory mechanisms. And of course, really, the main tenet of why we would actually transfuse and give blood products is to optimize circulating blood volume, and it's to prevent end organ dysfunction and to maintain oxygen delivery. And so it's not without harm. And so like anything else that we do in medicine, whether it's in the surgical critical care unit or elsewhere, even in the ambulatory clinics, when one's deciding what type of diabetic medication or what type of antihypertensive medication to prescribe, we always have to consider what's called the risk to benefit ratio. And there's a saying that says, first and foremost, do no harm, right? Because the reason why we're in this is for patient care and to make the health of our patients and our nations better. And so there's both infectious and non-infectious causes that can occur in the acute and even in the delayed setting. And certainly in this critical care setting, we do see three that come with acronyms, Charlie, Trim, and Taco. And so transfusion-related acute lung injury, transfusion-related immune modulation, and of course circulatory overload. So this is a table from a study that was published, actually as a review article by Dr. Holst, who's done a lot of work looking at red cell transfusions in the ICU setting. And as you can see here, this list is by no means considered complete, but it really illustrates what type of issues can be encountered within the framework of using blood transfusions. And the reason why in the balance, we really don't want to give a transfusion in an asymptomatic patient. So I think the key thing here again is really looking at changing the patient's physiology if they are symptomatic, and I'll explain what that means. And again, you can see that the common blood-borne illnesses, blood's now tested worldwide, so the risk is extremely low for all of these bacterial type entities and viral entities. But there's also still clerical errors that occur when patients are given the wrong unit. And it's still considered to be of such significance, the acute hemolytic transfusion reaction that's IgM mediated, such that they still appear in questions for our American Board of Surgery in training examinations. And the reason that we don't have to transfuse very readily, particularly in the case of anemia, is that the body teleologically has a number of compensatory mechanisms to mitigate the effects of a low red blood cell count, which also equates to a low hematocrit and hence a low hemoglobin. And so there's decreased blood viscosity, right, as opposed to a situation where there's polycythemia. And the other thing that happens is that there are receptors in the body that detect oxygen tension, so to speak. And what happens is, with a sympathetic outflow and a compensatory mechanism, it results in an increased cardiac output, which makes sense teleologically. If you don't have enough of the vehicle to transport oxygen, you have to just keep pushing the same vehicles through the circulation more fast or more frequently. And so the cardiac output will increase, and it's helped by the decreased blood viscosity. And then for reasons that are well worked out biochemically, the oxygen dissociation curve shifts to what we call the right. So for the same PaO2, hemoglobin is less saturated. So what it means is that the binding of affinity for hemoglobin and oxygen is decreased, so what ends up happening is that it's released much easier to the tissues. And of course, there's what we call shunting, not intrapulmonary shunting, but shunting in terms of blood being kept away from organs that are not as vital, like your skin, and perhaps not so teleologically your gut, affecting your gut microbiome, but really it's preserve blood flow to some of the most aerobic organs in the body, so brain, myocardium, and renal cortex. And then, of course, the tissues are able to increase oxygen extraction, but some argue that's really more of a mathematical element, but nonetheless, through a series of animal studies, it does appear that the tissues are capable of increasing oxygen extraction. So against this backdrop, then, if the body has all of these compensatory mechanisms in a patient who is anemic, where and when do we make that determination to transfuse when there's all of these compensatory mechanisms? Well, at the bedside, we know it has all to do with physiologic reserve. And not every patient is the same. Not every patient has the same degree of physiologic reserve such that they can mount these responses. And if you think about some of our critically ill patients, they may not be able to mount an increased cardiac output. They may have a depressed myocardium and what we call a flat myocardial function curve in the absence of adjunctive inotropic use, for example. And then when you think about the oxygen dissociation curve, some of our patients may be acidemic or alkalemic, and so the ranges of pH and also temperature will affect that dissociation curve. So it's a little bit more complex than what I tried to portray, but nonetheless, this is where then the decision to do research in this area came about. What's appropriate for the critically ill patient? So investigators who were interested in pursuing this topic then decided, well, what are some general guides for red cell transfusion that transcend anemia or a quote-unquote low red blood cell count? And one thing that I do have to say to qualify this, when reference ranges are set up, what we sometimes misappropriately call normal ranges, what generally happens, the tongue-in-cheek statement is that they take 100 otherwise, quote, healthy volunteers, draw their blood, they calculate the point of central tendency, the mean, plus or minus 2 standard deviations. And there and behold, that is your reference range. Understanding that 2.5% will be on the low end, 2.5% will be on the high end, but they're not abnormal clinically. It's just an artifact by virtue of how these ranges are calculated. So that's the other thing that has to be factored in. But there are some instances where we consider transfusion. So if there is diminished oxygen in the arterial system, if the lactic acid levels are actually increased, there is a decrease in the mixed venous oxygen, bicarb or base excess level, and sometimes tachycardia or ST changes that would imply that there's an increased myocardial oxygen need in the setting of ischemic changes electrocardiographically. So those are some of the general reasons one would consider transfusion that would make sense from a physiologic or clinical standpoint. And then what happens is there are entities out there that publish these guidelines or these white papers. So no different than other societies in Asia, in Europe. The United States has an entity that we now call the AABB that used to stand for the American Association of Blood Banks. And so they publish guidelines from time to time. And so way back, decades ago, they published some of these guidelines. But I just want to point out this most recent guideline set that came out of JAMA in 2016, now about 4 years ago almost. 30-day mortality was evaluated. Oh, thank you. 30-day mortality was evaluated, and you can see that there's a number of studies. But the thing I want to point out is that all of these studies were done not in ICU patients, but there are heterogeneous groups. So some are inpatients. There's a few mixed in here that involve patients in the ICU, looking at some of the restrictive thresholds, less than 8 or 9, versus a much more liberal threshold. And the key point here is that when you look at this forced type graph, you can see that in general, there are no studies that clearly show in an unequivocal fashion whether a liberal threshold or a much more restrictive threshold is actually beneficial or harmful in terms of 30-day mortality. So what happened was there was a trial that was done called the TRIC trial almost 2 or more decades ago that actually looked at the liberal versus the more restrictive transfusion threshold and showed that the restrictive threshold is probably no worse than the more liberal threshold. And so even if this was here, even if entities like the AABB, American Association of Blood Banks, published guidelines, it wasn't clear what was actually occurring across the spectrum of centers. So this was published in Critical Care, and so a group began to do an inventory using a SurveyMonkey type platform, and they went through all of the societies that involved critical care, had this sent out to critical care practitioners, had this sent out to residents, fellows in critical care, other healthcare workers in critical care. And this was on the heels of Jean-Louis Vincent's publication when he did an audit that showed that at least in the ICU setting, it looks like the number of red cell transfusions have decreased. And so this group said, well, we really need to look at 2 things. Do centers across the nation as a start, or in different centers, have thresholds, and do they have protocols, and are the protocols adhered to? So this is what was found. So in general, you can see here the majority were intensivists. The majority were anesthesiologists or individuals who were internal medicine based in terms of their primary specialty doing critical care. The type of units, and you can see in this study that there was a predominance of surgical ICUs, and so I thought this was a good one to sort of reference. And you can see the size of the beds. In terms of most being generally less than 15 beds or so. And in terms of the individuals that staff this, most of them tended to be anesthesiologists, right, followed by internal medicine. So that was used as one of the explanations for the findings. And so as you can see here, in terms of the types of patients that generally were made to adhere, so to speak, to the more restrictive threshold versus the ones that were not, the ARDS patients, the ones with traumatic brain injury and ECMO, tended to be the ones where clinicians, again, this is of their own accord, this is just a blanket survey, tended to transfuse these patients to a much higher level. But again, despite a 40-question survey, they were not able to drill down in terms of determining precisely why these types of decisions were being made. But the presumption was that it was because at the bedside there was some clinical determination made that the patients were either very symptomatic or not only were symptomatic but would actually benefit in a positive way from transfusions. And so they also looked at least at some of the causes whereby there tended to be a higher use of the triggers. And as you can see here, these are some of the more common ones from lactic acid elevation, hypotension, tachycardia, arrhythmias, acidemia, things that we would normally encounter in the critical care setting and things that would actually govern how we go ahead and treat patients. So The TRIS group decided to look at, in a multi-center way, what the outcomes were stratifying patients who had sepsis, severe sepsis or septic shock in 32 ICUs in Scandinavia. And so this is a summary slide of their data. And basically what I wanted to show is despite the subgroup, this is a subsequent post-hoc analysis, chronic lung disease, hematologic disorders, cancer, surgery, et cetera. And in terms of looking at the diagrammatic relative risk and the confidence interval levels, they really found that even in this post-hoc analysis, looking at the subgroups a few years later, that there wasn't much difference in terms of how patients did, whether they were on a more restrictive threshold, less than 7 grams per deciliter, or one that was on a higher threshold group where the number was 9 grams per deciliter. So having said that, what we do know is that the restrictive transfusion thresholds in the critically ill, at least based on some of these randomized studies, fare no worse. But there actually may be some cohorts that will benefit, such as a traumatic brain injury, acute coronary syndromes, or the patient with MI or small vessel heart disease, patients with acute sepsis perhaps, ECMO patients, but the jury is still out. There still needs to be research that will be done in these areas. And perhaps some of the inroads that will be made will be looking at other measures of perfusion. And so I mentioned in my previous discussion, we can look at, through the blood volume assessments, we can look at red blood cell volume. We can see what the normalized hematocrit or the corrected hematocrit is relative to the laboratory hematocrit. And in many cases, it will reveal what we call occult anemia. So it's a patient, if you look at the laboratory hematocrit, it falls within the reference range, but that may sometimes be a virtue of the fact that the plasma volume is a slight decrease, but not enough for the patient to manifest the full-blown signs of frank hypovolemia. And what happens, of course, if you replenish the plasma volume, then you actually demonstrate that anemia was indeed present. And so by looking at red blood cell volume through this methodology, we're able to make the determination as to whether or not transfusion may be needed in a patient, for example, who's demonstrating hypoxemia. And we know based on some of our other methodologies that it's not due to a pulmonary cause. If it is, then of course we have other measures, increased PEEP, proning, sometimes ECMO and bad ARDS. But we have methods that we can use. But if it's a non-pulmonary course, then we look at hemoglobin, cardiac output, things of that sort. And then if we find that their red blood cell volume is diminished in the setting of hypoxemia or an oxygen deficit, we will strongly consider transfusing those patients, because that's the easiest thing to do, is to effect a change in the red cell volume before we start doing things like adjusting their mean arterial pressures or adding inotropes. Because again, when you add inotropes, you're going to increase your myocardial oxygen consumption to a degree because of increased contractility and wall motion, wall tension. And then, of course, the transcutaneous oxygen saturation. If a patient is anemic and they're meeting the perfusion endpoints, then even if their hemoglobin level is 6, then we might not necessarily transfuse to the 7 grams per deciliter trigger. On the other hand, if the hemoglobin is 10, but they're not meeting the perfusion endpoints based on transcutaneous oxygen measures, and as it turns out the red blood cell volume shows a deficit, then we will, in that patient, if it's clearly a non-pulmonary cause of hypoxemia, consider with these additional modalities transfusing red cell products. And certainly there are other options, synthetic erythropoietin, but it does take time. The studies have showed that there really isn't a survival benefit. That's one of the hallmarks that we look for, because death is a binary event. It either happens or it doesn't, so it's very easy to measure. It doesn't have inter-rater variability. And at the same time, though, there are increased risks of thromboembolic complications, so just a little bit of caution there. Iron supplements does take a while. Oftentimes it's used in combination with erythropoietin. And again, the artificial blood concept showed early promise but did not come to fruition, which includes the hemoglobin binding oxygen carriers, things like the plurifluorochemicals. Meta-analysis that was published relatively recently of 16 trials of over 3,000 patients showed that there's a 30% risk of death renal dysfunction, myocardial infarction, cerebrovascular accidents. Essentially, the rate-limiting step in all of these is vasoconstriction. So in summary, red cell transfusion thresholds are something that are there that we can use as guides. But again, the cautionary tale is that we still have to take other measures into consideration. A lot of those studies were done in quote-unquote otherwise healthy trauma patients, but in the critical care setting, we have a vast plethora of patients with different underlying etiologies and physiologies. So we need to take all of the data points into consideration to collectively make the right decision, and as an example, sometimes integrating other measures. So again, I do want to say thank you to Dr. Hong, a very visionary lady and a role model, I think, and certainly been aware of her work across the Pacific and all the great things that are happening at Asan. I got to meet Dr. Im also, and so truly impressed with the medical center, and had a great time getting to see parts of South Korea. As you can see, I put together a little collage of some of the best things that are here next to Asan Medical Center. So with that, I'll be happy to entertain any questions.